Everyone, nice to see a large group here this afternoon. A lot of y'all people are people we need to talk to, I think. I guess you'll be dropping around later. We talk over things. Good afternoon. This is the first meeting of the Senate Finance and Appropriations Subcommittee for Health and Human Resources for the 2023 session, and it is our custom to begin just prior to the opening of our session because we have a very heavy workload and we like to get started early. I'm Emmett Hanger, Senator from Augusta County, and I have the good fortune to co-chair this subcommittee with our committee chair, Senator Howe. So I'll just get everybody else to introduce themselves.
Thank you, Senator Hanger. Hi, I'm Janet Howell. I am co-chair of this subcommittee and with Senator Barker, co-chair of the full committee. Human services are the most important part of the budget to me, and I'm going to be trying to make certain that we adequately fund our most important priorities, and those will be, of course, mental health and actually education issues, in my opinion.
I'm George Barker, and co-chair of the full Finance Committee. And I've been working ever since I got here on health and human resource issues. So.
And my name's Creed Deeds. I'm in the 25th District right now.
Hi, I'm Adam Eben from the Northern Virginia, representing Alexandria, Arlington, and Fairfax. Thank you.
Yeah, with Senator Deeds' comment, as y'all are well aware, some of us are going to have to be agile if we want to come back. So we'll see how that works out. Subcommittee, as is typical for us, is going to have 4 meetings before we report out. This being a short session, it'll be a quick turnaround before we report out the full budget. We're going to start today in the subcommittee with remarks on the governor's proposed budget from the Secretary of Health and Human Resources, and then have a budget briefing to better understand the governor's budget as it relates to behavioral health and developmental services. In future weeks, the subcommittee is going to receive briefings from other HHR agencies, including a staff overview of the budget issues before the subcommittee, and consider any other HHR-related bills that are referred to the subcommittee. Over the years, the subcommittee has worked hard to invest in behavioral health, the developmental disability system, improving the Medicaid program, and investing in programs and services that help those most in need. And we've been assisted by that in recent years most capably by our staff, Mike Tweedy, who y'all spend a lot of time talking to, many of you all, and we're very dependent on his knowledge base as we work through these major issues. The governor's proposed budget includes additional investments in behavioral health and developmental services. The subcommittee will closely be reviewing these proposals to best determine how they would build upon the significant investments that we've already made in this current existing budget. In addition to behavioral health, we'll be looking at Medicaid provider rates and building upon the significant investments the subcommittee advanced last year to ensure Virginians on Medicaid have access to appropriate health care providers. The subcommittee will also be looking at the procurement of the Medicaid managed care contracts. These are the largest contracts the state has, and it is essential that the Commonwealth ensures the maximum value from these contracts to ensure a cost-effective Medicaid program that promotes good health outcomes for the Virginians who need access to that care. And of course, Mr. Secretary is very well versed in managed care and all the contracts that we will have. We'll be looking at Medicaid provider rates and building upon, well, I think I said that already. Today we have with us the Honorable Secretary John Littell, Secretary of Health and Human Resources, and Nelson Smith, who's disguised himself over recent months, but the Commissioner of the Department of Behavioral Health and Developmental Services. And as you all are aware, it's significant, as the chair has indicated, because roughly 30% of the whole budget runs through this subcommittee. And if we entertain half of the amendments y'all are proposing, it'll be 40%. But that's something we'll be talking about. Before I begin or go any further, does any member have any comments as we get started? If not, Mr. Secretary, we'll turn it over to you.
Thank you very much, Chairman Hanger. And I just want to say Nelson is hiding from me, not from you also. But thank you to the members and Chairman Howe as well for the opportunity to be here today. So Mike is very clever. He said, "Oh, it's just informal. Just say whatever you want." But I thought I would just
People listening, though.
what you have to say. But I thought I would just hit maybe 6 categories relative to the budget that I think are important to you and certainly to us. And first, as you stated, behavioral health is clearly the number one priority for the governor's amendments this year. In the budget for fiscal year 2024 that was previously approved, you included almost $440 million in new spending for mental health. And the governor is recommending an additional expenditure of $230 million. And I think Commissioner Smith and his team will go through the details, but let me just hit a couple parts of that. First off, you all have been dealing with this for quite a long time and, put a lot of good components in place. We really looked at the whole kind of continuum of care and looked at pre-crisis services, crisis services, and post-crisis services. And certainly, we end up spending a lot of our time on crisis services because that's where a lot of the attention is and certainly a lot of the needs. And but we all know that in any part of healthcare, the services before and the services after are really what are going to make a difference. But to do that, we really do have to address our crisis system and build a crisis infrastructure that will allow us to do that. So we spent a lot of time really looking across the country to figure out what were best in class practices. And this is, again, not new. You all have talked about this, and Deeds has talked about it in his committees for many times. But we based ours on the Crisis Now approach, which is really considered best in class and is really best utilized in Arizona. And that model allows us to use algorithms to determine what our needs are going to be and at what level of the crisis system they are. So right now, more often than not, someone's in crisis, whether in a TDO or an ECO or just on their own volition, really the only alternative a lot of times is inpatient hospitalization. And that clearly is important for many people, but it's not really the only place. So you all have supported and funded mobile crisis units in the past, as well as CRCs. And our budget amendments will fully fund the number of mobile crisis units that we believe are needed, which is 70. And that would be fully this year. And then going forward, we would also be investing in crisis receiving centers and crisis stabilization units as well. So really thinking about the whole system of care. So mobile crisis units, crisis receiving centers, CTACs, CSUs, really thinking about different ways that we can do that, as well as adding on some services to determine if creating psychiatric services inside or alongside acute emergency rooms will allow us to better serve some of the patients. So those are some opportunities that the department will sort of lay out in more detail, but we really think that we have an opportunity to kind of build out a crisis infrastructure that will really meet the needs of our citizens today. I was last week got to visit a pending crisis receiving center in Prince William County, which will likely be probably the best in class one that we have. We have good ones in Fairfax County, and they're going to kind of build out an 80,000 square foot space that will have a CRC, a CSU, will have all the services from the CSB inside one place. Really will be a true, one-stop shop for everyone, both for law enforcement as well as for people that come in on their own. And I think, this is an opportunity for us to really leverage a lot of the best practices we've seen in various counties to make sure that we have consistent services across the Commonwealth. And, along the way, it is important to think about the medical needs of our citizens, but it's also important to think about the burden that we have on law enforcement. And I think building out the crisis infrastructure will allow that burden to be lessened, continuing to look for ways that we can put co-responders and others into the market, I think will be really helpful. In addition to that, we are investing in prevention as well as post-prevention services like housing and mental health group homes. We have some really good experience in our colleges as well as in our K through 12, and we want to build on that experience, so we have included money to build out a telebehavioral health service for colleges, as well as to start to look for ways that we can do that in K through 12 as well. We're a little careful about what we have in K through 12 because we have a lot of programs that really are very detailed, the ones that work with students, and we want to make sure that the telebehavioral health complement that rather than replace it. But I think there's some opportunities there. We did put a $15 million in to expand our school-based services as well. We had a $2.5 million pilot for that. That's been very positive so far. So I think we'll do that. On fentanyl, we have added $16 million in opioid abatement activities, including a campaign to reduce fentanyl poisoning among young people, as well as some opportunities to expand our supply and our use of naloxone. We're sort of in a place now where the potency of fentanyl is just getting stronger, so we're seeing a lot more places where more than one Narcan dose is needed. So making sure that we have adequate supplies, that we're training as many people as possible. The governor and the first lady got trained in November, and now they would like everyone in PHP to be trained as well. But it really is an easy thing for people to be trained on. There have continued to be articles about really the potency of fentanyl that's coming into Virginia. In Southwest, a number of situations where 3 doses of Narcan are required to revive individuals. There was an article this weekend in the New York Times about Trank, where they're mixing veterinary tranquilizers with fentanyl, which is really unbelievable. But looking for ways that we can really think about this from our side, as well as looking at the work that we're doing with public safety to make sure that we're limiting the supply wherever possible. As expected, a number of our requests relate to staffing, and both retaining our existing staff and adding new staff where appropriate, as well as building out our healthcare workforce. So these include much needed salary adjustments to the Office of Chief Medical Examiner. I think our staff there, we have 20 assistant medical examiners slots. We have had 8 vacancies for the past 14 months. And our neighboring states, Maryland and North Carolina in particular, are paying as much as 3 times what we're paying. So we get individuals, we train them, and they get recruited by these states very quickly. And clearly, we need medical examiners because a whole bunch of stuff really relies on that. So that's one area, as well as some staffing needs at the Department of Behavioral Health, including also safety and security measures for our employees in our facilities, making sure that we have duress systems where appropriate, as well as other security procedures. Externally, the governor really focused on quiet heroes, police, teachers, and nurses. And so we're requesting almost $50 million for expansion of nursing education programs, an earn-to-learn program for nursing, and expanding loan repayment programs. We're also requesting funds to add 20 psychiatric residencies, and we would add more, but as you know, it's very difficult to find the slots there. Not so much a big budget item, but certainly an area I know is of interest to you, and that's the unwinding. And since I came almost a year ago, we've been really working with DMAS and DSS on just the process that they have, the IT systems that they have, and how they plan to staff the redetermination of Medicaid eligibility. As you know, that will begin shortly after the end of the public health emergency, which now we have visibility into that the federal omnibus bill says that will end on April 1st. And so we're really gearing up for that. And so we are requesting some ARPA funds for that, plus some money for overtime for DSS. One of the things that we really focused on is that most local DSS have about a 20% vacancy rate. And federal law requires that you can't use contractors to do redetermination. So one of the things that we've been working on is figuring out a way that we can supplement areas, local DSS, for instance, Richmond, where there is a good pool of employees, build that up in some of these areas to use them to supplement other counties, other regions that don't have the staffing. And but it will be a big stretch for DSS, but we are confident that we can do it within the time frame. Senator Hanger mentioned the Medicaid managed care reprocurement. We requested funds to do that and to bring that on board in 2024. That will allow us to better tailor our program, as you said, to get more value for our dollar, but also to better incorporate behavioral health in a more meaningful way and to further address disparities like maternal and infant health. It's also an opportunity for us to meaningfully reduce provider abrasion and assure a more available network. You also mentioned developmental disabilities. The governor has committed to ending the Priority 1 waiting list by the end of his term, and so we propose reducing it by 1/3 this year and following up each year with another third. So we've requested an additional $50 million in general fund for an additional 500 slots on top of the already approved 600 slots. And then lastly, as you mentioned, the budget requests some increases in Medicaid rates for personal care, respite, and companion services, which is long overdue and assist individuals and families who live at home and in their communities, as well as additional funds for early intervention services for young children. So as I noted, these are things you all have been working on for a long time, so there's nothing really new there. But I do think we have a real opportunity to, particularly in behavioral health and in Medicaid, to really deliver more and better services to our citizens. So I have a feeling I'll be back, so I thought I would just keep it really brief, but certainly happy to answer any questions or provide you more information.
Thank you, Mr. Secretary. Anybody have particular questions?
Toward the end, you mentioned that the governor's getting more slots so that we can get rid of the Priority 1. Last year, virtually all the advocacy groups came together and said, it's great to give us more slots, but if we don't have the personnel, it doesn't do anybody any good. And I think the legislature took that very much to heart. And I'm wondering what you are proposing in terms of increased incentives for employees, including the compensation.
That's 100% accurate. When we start the process, in fact, with the governor, we started with, can we eliminate the entire waiting list in 1 year, notwithstanding the cost, but if we could do that, and we can't, right, because there aren't the services available. So I think it's a multifaceted approach to that. I mean, one is just building up the services across the board. So thinking about the agencies that are there, are there ways that we can, a number of the nonprofits that provide services, are there ways that we can support them better? One of the ways to do that, I think, is through the Medicaid managed care RFP. Because if we can think of ways that we can make the process for them to be credentialed, to get paid for any kind of prior authorization or things like that, make that easier, whether we have a single form for all the managed care organizations or not. I think that makes it easier for the organizations, who have a very small margin to get by. On the staffing, I think there are a number of things. One is, I think some of the workforce stuff that we're looking at, we have been looking at everything, over the summer, I guess, we were able to make some changes through the Board of Social Work on social workers. So part of it is looking at all of our regulatory stuff to make sure that any place where we license or regulate a healthcare workforce, that we have minimized the burden on them and really kind of move them through so that we can get more people there. We have also been looking at ways to expand and will expand. It's not actually a necessary budget item, but expand some of our programs for high school students. We have one in the Petersburg area through the Department of Behavioral Health, but looking for ways to grow that just to get more people into the pipeline for that. And then clearly working with the CSBs on anything we can do to kind of speed up that process of people being both licensed and organizations being there. So I think that, we will continue to work with the advocacy organizations to think about where those services are needed. We know a lot of the things, you know a lot of the things. I mean, a lot of it relates to housing, it relates to supportive employment programs. And so in my experience, you can more effectively use your managed care programs for that. And I think they can be really supportive of that. But I think there are some opportunities for us there. So that's really front and center. One of the things I think the department will talk to you about is having a public dashboard where they can track those waiver slots. And so making sure that we look for places across the Commonwealth where there are hurdles to people getting the services, I think is where we can sort of bring the state's influence to bear.
Senator Barker.
Thank you, Mr. Chair, and thank you, Mr. Secretary. One of the issues we deal with in Northern Virginia is that we're not an island. We last week hit $12 as the minimum wage, and there are a number of people who are providing some of these services that are that prior to that, to last week, were making less than $12 an hour, and there are significant issues with that, and in many instances around, there are people who are providing services and who actually enjoy providing the services with the people they're working with, the individuals they're working with intellectual and developmental disabilities. But they end up saying, well, I can't make it on less than $12 an hour. And so I can go down the street to the retail stores, the variety gas stations, anywhere, and come up with $15 to $20 an hour. And in our minimum wage now is $12 an hour, and there is no additional authorization to go beyond that at this particular point. We did it over a three-year step to get to this part from the 735 or whatever it was previously. But in addition, right now we have significant competition because there are in Maryland, it's I think $13.50 or $14 an hour already in terms of what the minimum wage is, and in the District of Columbia it's over $16 an hour. And so we are actually losing some of the highly qualified and caring people when they have an opportunity to go somewhere else, and they're at a very low wage and need to be able to deal with that. And it would be helpful if we had some ideas in terms of how we can try to deal with that.
Okay. Other questions? Hey, just to follow up, Senator Howell was exactly right there. Last year when we talked about this, there just weren't providers, so we backed off from the number of waiver slots. And as you and I were talking as we came in the room, we're going to have to address that in a meaningful way, and it's going to be very costly to build that capacity to provide those services. So that's something that we'll have to be. You mentioned that you all have much more detail, and I guess that's one thing that I would focus on right now, because we will need to see some of that detail, I guess, or we'll invent it for ourselves probably in the budget in terms of direction, because all of us, are aware. Particularly, I mean, you're moving in a great direction as far as the crisis aspects of managing the program. But we'll all want to have our shot at making sure we think it's going the right direction with the detail that you can provide us.
Well, there are a lot of people behind me that can do that, but I will say that, I think when we looked at it, what we were talking about before is, you could just pick a number, whatever number you want, pretending that you're not a budget staff and budget committee, and you could spend it, right? $1 billion, $5 billion, whatever it is, we can find it in this, just in behavioral health. The reality is, can we be effective? Can we actually spend it in a meaningful way? I think is really important there. But when we looked at the history, and we spent a lot of time looking at what's been done over the past 15 years and the conversations. I've read many of Senator Deed's committee hearings from the past several years, and just hearing where the holes are and where the real pain points are. We tried to be as broad as possible, and though we focused a lot on the crisis section for a reason, I think that it's really important to look all across that. So we are trying to lift that up. That means that not everything that could be covered was covered. And I think it's partly we want to make sure that we're really meaningful, that we do this in steps, but we do it quickly. There are going to be things, pet projects of many advocacy groups or things that are important to you that we can talk about. One obvious one is we did not include the CSBs much in our presentation because we knew that JLARC was doing their work at the same time we were, and really did a deep dive for almost 9 months on it, and really support most, if not all, of their findings on that. So it is, there are lots of, when we get into the details, there are a lot of stuff that we could lift up that would be meaningful as well. And we are committed, and the governor is committed every year for the rest of his term to really come in with a significant investment in this and really be committed to it.
Okay, thank you. And another quick question, maybe just for my clarification, is you mentioned the emergency ending, but with the bill, are we going to be, I think we're going to be eligible for the enhanced rate as we unwind now under the provisions of that legislation?
It declines, so we have it for that quarter, but then afterwards. So the quicker we redetermine, the better off we are.
Okay. All right, thank you. Senator Howe?
Yeah. One of the programs that's been shown to be extremely cost-effective and humane is the permanent supportive housing. Are you all putting money into that? I can't remember.
Yes, we put $8 million more for 100 slots for individuals, and you are absolutely right. Every data point says put people in housing. I think they have like a 91%. They stay there for a year, and they're rarely relapse and things like that.
It
So
more
it's,
than pays for
yep.
itself.
Yep.
Yeah.
And
so
what,
you probably wouldn't have any objection if we put in more.
the administration has no position at this time, but no, I think the one thing is that we want to be careful. I think one thing is we wanted to tie it with the governor's initiative on housing, affordable housing, because I think it's part and parcel. But I do think that every program I've seen, there's lots of opportunities to do more.
Mm-hmm.
Okay, very good. I'll observe Senator McClellan has joined us, and y'all all are aware of her trajectory, I suppose.
Well,
but I'm wondering, after last week, will you really want to do that?
Well, yes. To be clear, though, I apologize for being late. Senate rules put me on the VCU Health System Board, and they meet a lot, so I apologize.
Okay, thank you. Thank you, Mr. Secretary.
All right, thank you very much.
All right, Mr. Commissioner, you up next?
Yes, sir.
Madam, Mr. Co-Chair, members of the committee, thank you for having us here today. As the Secretary indicated, we have a team of experts behind me that can't answer some of the questions. We'll have the people that know it all ready to jump in. So I'm going to spend most of my time talking about the governor's the Right Help Right Now plan. Hopefully you all had a chance or saw the announcement. The governor's support for behavioral health and developmental disability services has been unprecedented, and this plan is a turning point for our system. In the past, efforts in this area were largely concentrated in a single area, and to the Secretary's point, we looked at the whole system and looked at it, as the Secretary comments, often from a consumer's journey. What does it look like for a Virginian to travel through the whole system? So what we did was take all the information, data that we've had year over year, all the studies, and piece this together in a way that is, again, weaves that story. The hydraulics of our Virginia's fragile system cause these singular efforts to have downstream unintended consequences. So this approach is comprehensive, carefully crafted, and will roll out over the next 3 years. So when we talk about, when we focus on the crisis system, and things that we're going to go into the pillars. That'll be this year, but I ask to consider that this is a 3-year commitment as well, and we'll be continue our planning process. So the 6-pillar approach to address the behavioral health challenges encompasses crisis care, law enforcement burden, substance use disorder, behavioral health workforce, and service delivery innovations. DBHDS has budget items in 5 of the 6 pillars for the first year of this 3-year plan. There are funds in other areas like DMAS, public safety, and education, but we're just going to cover our budget today. So the first pillar, there we go. So the first pillar is to ensure that people experiencing a mental health crisis get some meaningful intervention that same day. These funds are critical to boost and to help Virginia's crisis system mature. Last summer, we rolled out our 988 system with the new number for mental health crisis, and currently we're getting over 6,000 calls per month, which we need to work on, continue to build our workforce for this. So national experts believe that 80% of the calls to 988 can be resolved on the phone, and so far our team is able to answer 91% of those calls the first time. So 988 will only be successful if people are connected to the services when they call. So the governor's plan focuses on mobile crisis and the residential components. Mobile crisis teams race directly to that person and help them in their community. So the fundamental aspect of 988 is that we need someone to call, and people need to be able to pick up the phone. There can't be elevator music on the other end. The second piece to that is someone to respond, and we always talk about getting help in your community. This system provides that help to a Virginian when they need that in that moment. And then the third piece is somewhere to go. So this plan builds out 30 more teams and helps staff the existing teams, which are currently at about 40%. And this will give us the ability to respond 24/7 and within a 1-hour radius of that population center. Also, there's a Medicaid reimbursement model, and we'll be educating the system on how to utilize the reimbursement opportunities. As you know, the system is new, so we need to help our providers understand how to maximize that to provide a sustainable business model. Overall, these funds will be huge to help with recruitment, one-time infrastructure equipment, vehicles, training, and also, as we noted, revenue generation model. People whose needs exceed the mobile crisis purposes may go into crisis stabilization units or crisis receiving center. The governor's plan would invest significantly in more centers where law enforcement can drop off people in crisis for immediate care. These centers are experts at behavioral health treatment and diverting individuals from entering a higher level of care. Not only is this more costly, but also to go into inpatient, but these crisis receiving centers are able to give them a Virginian the treatment they need right there, and the satisfaction rates are tremendous. So these centers can prevent 65% of the patients from needing longer-term inpatient care. And private hospitals will still be an important option for people in crisis. And this plan expands ways that we can work with private hospitals to provide safe and secure treatment in the medical care or in the emergency departments. These units, they're called Comprehensive Psychiatric Emergency Programs, or CPEPs. They're smaller units that are attached to emergency departments, and they average about $3 to $6 million per unit. And they provide a way for patients to get critical care immediately. If there are any questions as we move along, open to answering those. People in crisis, you hear this all too often, are sitting in emergency rooms for days on TDOs. The average is 43 hours statewide, almost 2 days. And law enforcement who have custody are waiting with them. This is horrible for the person who is in crisis and often not getting the treatment during this time. And it's terrible for our Virginian communities who need their officers with them, and they're just sitting in a hospital for hours. We started a program last spring by repurposing funds for a pilot program in Southwest Virginia that allows off-duty law enforcement to be paid to take custody and stay with TDO patients while a bed is located. 9 agencies have signed on and 6 are in discussion. and there's interest in other areas of the state. This is clearly a Band-Aid until the crisis system matures, but the governor's plan will provide some immediate relief in this area. Also, the governor's budget would amend currently earmarked language for alternative inpatient treatment options to allocate $1.5 million for non-inpatient services for individuals at risk of discharge from private inpatient settings into our state facilities. Some of these individuals may not need continued hospitalization, but because we don't have community services or transition services, it leaves them to be likely candidates to enter into our state system. Next slide. Going on to Pillar 3, the governor's plan would help school divisions to contract for mental health services with public or private community-based mental health providers. This will lead to timely identification and treatment for youth through enhanced screening, assessment, prevention, and early identification and referrals to community-based providers. 22 school districts are now in pilot for these services, and the expansion will add an additional 25 school districts across the state for a multi-tiered system of support for assessment and therapy. The governor's expanded housing opportunities would also provide 100 additional beds through an additional RFP process for individuals who aren't the right fit for transitional housing and they may need more permanent placement. Their levels of care are generally the highest intensity, and this is why they get stuck in the state and private hospitals. This also goes towards forensic patients that the court won't discharge without a placement for this level of care. The governor's plan will also ensure the waiver management system is maintained and upgraded to support interoperability with the community service boards. Also, DBHDS is waiting to hear back from SAMHSA on our application for a federal grant for more certified community behavioral health clinics, also known as CCBHCs in Virginia, starting with our CSBs. CCBHCs are specially designated clinics that provide a comprehensive array of 9 mental health and substance abuse services for children and adults. Overall, the CCBHC model fosters increased accountability and moves towards a more formula-driven funding model and ties state funding to Medicaid. As of December, moving on to the waiver slots, there are nearly 14,500 people waiting on a waiver. Of those, just shy of 3,200 are considered Priority 1. These 3,200 people will need services in a year or less. The governor's Right Help Right Now plan aims to eliminate the Priority 1 wait list by the end of his term, and the funding reduces this list by 34%. While we were developing the Right Help, in the development of the Right Help Right Now plan, every DD listening session and many of the surveys voiced a strong concern on how hard it is to get a waiver slot, providing a lifeline of services, peace of mind, particularly for those aging parents who are still caring for their adult children. The governor's additional positions of waiver management system augmentation that you saw in the previous slides will provide critical support for these new and future slots as well. Importantly, as a companion to the new slots, the governor proposes to increase provider rates for personal care, respite, and companion services by 5%. This is a good slide. The waiver process. We all know it's a very complicated system, so we tried to make it as easy to digest, more easy, I should say. But the bottom line is the agency, DBHDS, we have full confidence that those 500 additional slots will be allocated quickly without the one-time delays that we experienced in 2022. Virginians need those slots right now. Of note, 2022 was unusually challenging for waiver slots. In November, DBHDS reported 314 individuals who had received waiver slots but were not receiving services. As of last week, 138 have since activated services. So far, we've only found 16 that haven't found a provider, and we're helping us connect them to those services. It's important to understand that the regulatory change last year that led to the delays in the system in assigning the waiver slots has been fully resolved. And after an intensive effort, we have all of the documentation required by the regulation, so this year's process will be expedited. The chart on this slide explains the process of to assign the waivers. It's complicated, but was carefully designed to ensure the process for limited slots remain fair. DBHDS is also working with the community service boards now to ensure critical elements are in place ahead of the July 1st allocation date. Of note, once the state allocates the funds, we must seek CMS's approval for the match. This is a process that could take up to 90 days. So meaning July 1st, we get the allocation, we can't just get them out the door immediately. We have to wait on the feds. Also, the governor's new funds for positions for service authorizations will speed things up as the number of slots grows over the next 3 years. We're excited about this effort and is the right thing to do for families who are under so much stress. We will not let them down. Next slide. Even though we're making great strides, it's been terribly difficult to get ahead of the opioid crisis. In 2021, we saw a 16% increase in overdose deaths over 2020, and in 2020, there was a 48% increase over 2019. Fentanyl has caused or contributed to 76% of the fatal overdoses in 2021. A key weapon in this fight is naloxone to help reverse the effects of an overdose until help arrives. Last year, 30,736 naloxone kits were distributed to the local health departments, community members, CSBs, and first responders. And 11,332 doses of naloxone were delivered to harm reduction sites. Pharmacies were still by far the largest providers of this life-saving medication. The governor's plan will make sure naloxone is available for more Virginians to fight this terrible epidemic that continues to ravage our communities and the nation. Next slide. Next, I think this is near and dear to everyone's heart, is the workforce. All the policies, procedure, processes, they mean nothing if we don't have the people to carry them out. So we can build remarkable plans, again, but we have to have the people to execute. We're going to be targeting some of the lowest paid state hospital employees. Food services and environmental services in our state facilities. Many of these workers' pay is as low as $12 an hour. System-wide, there's a 32% vacancy rate in these positions, but it is as high as 50% in some of our facilities. As you can imagine, these vacancy rates have a huge impact on our operations. Patients must receive healthy meals and facilities must be clean, especially as COVID-19 cases still persist. There are also several additional items in the governor's budget proposals. First, the funds that are proposed to address the IT, security, and cybersecurity. Next, the forensic population in the state hospitals are growing at a rapid rate. Both Eastern and Central State Hospital currently have about 90% of the patients with forensic status. That leaves us with only about 30 beds at each facility for civil patients. The governor's plan includes additional evaluators and data tracking, not only to make this evaluation process go faster, but allow more capacity to critically examine when treatment in the community instead of a state hospital is possible. Next, combining funding streams for alternative custody and alternative transportation will give us the flexibility needed to direct the dollars to the greatest pain points for law enforcement and our system partners. The amended language also clarifies that alternative custody and transportation programs can be administered through contracts through state, local, or private contractors, or other methods as necessary to implement the program. And finally, the governor's budget would broaden the language to all older adults for discharge programs beyond dementia to allow the discharge of more individuals. Next slide. We'll just pause there. I know that that was the governor's budget, and then we'll go into the permanent supportive housing and then the request of the VCBR.
Senator Deeds?
At one point, a significant number of the forensic patients at Eastern State were discharged with misdemeanors. Do you have any Is that still the case, or is that trend slowed, or do we have a handle on it at all?
I think the rate has increased.
Since we last reported, the rate is about the same. What we're finding is that the greatest proportion of folks are at our hospitals, including Eastern State, for restoration services. Yes. But we felt that the misdemeanor population was one that we could target in the sense that we could work with the court system to find out if there was a better way to support those in outpatient.
Well, Mr. Chair, are you working with the court systems to figure that out, or?
We actually have a pilot program that we've implemented at Eastern State Hospital, where we have someone to go out and actually take a look at the services that can be provided in the jail system. We also have that person reviewing cases and providing recommendation as to if someone can be supported outpatient versus inpatient. We don't have a large team working on that, but it's something that we're aspiring to, and we do feel that we can make some movement in that area.
And Mr. Chair, it was my understanding that this is a phenomenon you primarily see at Eastern State Hospital. Have you figured out, are there certain localities where these misdemeanors come from?
Well, Eastern State has a large number because they are serving the two largest jails in the state. Western State has a larger forensic population as they are supporting forensic patients that would be served at Northern State, but Northern does not have the capacity, so their folks are being diverted to Western. So there are some nuances per region.
You don't have as many misdemeanors at Western State.
We can take a look at that data
Okay.
and share it with you.
Okay, I would appreciate that.
Yes, sir.
Okay. Other questions? All at this point? Okay.
All right. All right, permanent supportive housing. And then following that, we'll do VCBR. In FY22, nearly 1,600 people were served directly in DBHDS's PSH slot, and funding is fully obligated to assist nearly 2,000 individuals. In FY22, most state funding is used to support 25 permanent supportive housing programs serving 27 CSB catchment, and new service contracts are in place to serve individuals through DBHDS's partnership with Virginia Housing to lease tax credit units. State hospital utilization was examined for a cohort of 1,449 individuals who entered PSH at least 1 year before June of 2022. The cost of the state hospital bed days for this group in the year preceding PSH move-in was $36.1 million for 359 hospitalized individuals. The cost for 134 individuals hospitalized in a year after moving into PSH dropped 76% to $8.5 million, reflecting the state hospital cost reduction in more than $27.6 million for this cohort. Excellent. Through FY 2022, there were 272 discharges directly from state hospitals into the permanent supportive housing. Nearly half of those PSH participants had a state hospitalization in their lifetime. PSH programs are effectively targeting individuals with long histories of homelessness and repeated engagement with crisis, hospitals, and criminal justice systems. While targeting individuals with significant support needs, programs have achieved positive outcomes. In addition to the 76% reduction in state hospital costs, 91% of individuals remain stably housed for at least 1 year after move-in. Excellent. Our PSH needs assessment report, January 2023, estimated that approximately 7,000 additional PSH slots are needed to address the priority issues. A few of these notable initiatives that we have, first is our statewide Supporting Community Integration Program, which is a partnership between CSBs and state hospitals to improve access to integrated settings such as PSH at discharge. Next, in Northern Virginia, we have multiple projects, including ARPA-funded Supportive Housing Institute, which includes 185 PSH units. We also have a project that pairs assertive community treatment with PSH in Fairfax. Funds will be used to start an ACT team, which will be paired with rental assistance. Finally, interagency collaboration is imperative for the success of PSH. Our low-income housing tax credit partnership with Virginia Housing includes PSH service contracts with 3 nonprofits and a pre-development partnership with the Department of Housing and Community Development. If there are no questions with PSH, we'll move on to VCBR. Mr. Chair.
Mr. Chair, have you ever looked at the population served by PSA, by permanent supportive housing and May determination? You know, I've always thought that so if somehow you married this up to the extraordinary barriers list, you could reduce the number of people that are on that list. Has there ever been any effort to do that?
Yes, sir. As a matter of fact, I think there's a specific line item that the Secretary mentioned, the $8 million to target a group of individuals on the EBL that have serious mental illness. So we are looking at ways that we can target that specifically.
Mr. Chair, one of the important things about this is that it's not time limited. People can go and stay without, I mean, it provide people with long-term stability. That gives them the best chance to live their best life. Do you know how long people on average stay? Are there people there for multiple years, and have you tracked people to figure out whether they go back to family or what happens when they do leave that permanent support family?
Sure, I have our expert. I know that the data that we're talking about here is a 2-year look just for this specific study, and also the annual report has a lot of the detailed information. It should be coming in the next couple of weeks. The annual report that you requested will have a lot of that information in it. I think the one that was published last year would probably have that same information.
Senator Deeds, is your question how long do people stay in permanent supportive housing?
How long do they stay and where do they go?
Average length of stay is 36 months. That's skewed a little low because of how many people continue to move into PSH, but 36 months is.
Do you know where they go at the end of the 36 months?
We do. Typically, it's to other housing, but sometimes people go to higher levels of care or pass away, unfortunately.
Yeah.
So the $8 million on slide 5 is targeted to the extraordinary barriers list, is that what you're saying?
Yes, sir. It's part of that. All right, brief update on VCBR. VCBR leads the nation in safe conditional releases from similar facilities in the nation. A testimony to the rate of success of the treatment program at VCBR. In fact, it has a 99% participation rate of its residents in active treatment, which is a civil commitment and voluntary. Facilitating safe discharges and working with the DOC on screening are factors that help get VCBR, the census, under control in recent years. The census has stabilized and currently stands at 410. However, we expect the census to increase, though at a slightly slower rate than previous years. VCBR has occupied its transition unit, a medically complex unit, and has incorporated space for individuals with DD and serious mental illness, and for those with age or mobility limitations who cannot occupy a top bunk. Once the construction is complete, we will transfer the female unit from Central State to VCBR, and will expand our vocational training and group treatment rooms, which were all severely lacking in the original facility design. Like most facilities, COVID-19 had a significant impact on the operations of VCBR at the onset of the pandemic. VCBR worked closely with the local health department to reduce the impact of COVID on operations when positive cases occur, and 91% of our residents are fully vaccinated. COVID cases still occur, so treatment teams are able to quickly adjust from group treatment, which is the preferred method for SVP treatment, to individual treatment meetings with residents when movement is limited due to unit quarantine. Any questions?
Well, because I was one who resisted the expansion down there as long as I could. But the, how about the release rate? What, anybody getting out of there?
Yes, sir. What's the average?
I can look that right up. I can get that back to you too.
Okay.
Yeah.
Okay, thank you.
Matt, Mr. Chair, I just want to make sure I understand the population being served there. These are people that have been convicted of crimes, that have done their time, and they're determined to be a danger, so they continue to be incarcerated there. Is that correct?
Yes, sir. Sexually violent predators to receive treatment. And our recidivism rates at our facility is exponentially higher than those of other facilities in the nation.
So you're saying we're one of the worst in the nation?
We're one of the best in the nation when it comes to.
It's the reverse.
Sorry, it's yes. I think it was my neck was turning.
Well, that's,
Yes,
that'll
ma'am.
relate to the unanswered question, though, get more information on whether we're letting very many people out of there. You don't have much recidivism if you never let them out.
I would guess that it would correlate to the treatment that it's successful.
And we can share the release rate. I mean, we have discharged 32 individuals since 2018. And of course, our census right now is 410, but we can get the specific.
Okay,
numbers for
great.
another time.
Thank you.
Matt, Mr. Chair, could you also tell us how much time these people on average have already served by the time they get to the facility, and how much time they spend in the facility?
Sure.
That's good. Well, if there are no further questions, I guess that concludes the remarks.
Okay, are there other questions while we've got the Commissioner up front sitting here? Well, we certainly appreciate you,
Yes, sir.
you and your staff putting this together for us, and look forward to conversations as the session begins.
I imagine we'll have more.
All right, very
Mr.
good.
Chair.
Thank
And
you.
I will note that my beard was brown when I started last year,
Okay.
so that
Okay.
also came as a surprise.
Okay. You're feeling the stress, are you?
Matt, Mr. Chair, who's going to address capital outlay? I see a slide here.
I can do the same.
We did get a note this morning, so there's decent idea. That might be it.
I did.
Lots of news. Yeah.
Yes, Mr. Chair, it's wonderful news. We broken ground at Central State Hospital and construction's underway.
Do we have an idea about how much additional? Do we have an idea about how much additional money we're going to need?
I think we're waiting to see what those numbers are going to be.
Okay.
I'm sure Joe's working on that. Capital outlay. So we did a security review of Eastern State Hospital. As you know, it's been in the news many times. I think the original design, it was not made to treat the current population. And so we've had quite a few elopements. They were able to go through the walls. It's not a hardened facility. I think it's more of like, it's designed as an assisted living facility where you can actually, so any rate, we'd like to undertake hardening the facility so the patients that we treat now will be able to remain in a safe environment. So that's the largest chunk of that is, I mean, we had to build a DOC grade fence, which is quite expensive.
Mr. Chair, the $16.9 million is above the fence, over and above the fence, or does that include the fence?
I believe that's inclusive of the fence.
It is a different project.
Okay.
It is.
We had a project that was previously approved to harden Eastern State Hospital with a different scope of work. The scope of work was more about anti-ligature risk mitigation and other internal material issues. Once we identified the elopement risk, we worked collaboratively with DGS to change that scope of work or include the hardening of the bathrooms and the bedrooms. And so that existing project will support the most immediate need. DGS did request additional funding, which I think is the fourth line item on the slide that you're looking at, where it talks about Eastern State hardening, so that's additional funding on that line item to assist with supplementing that originally approved budget. So when we requested the 16.9, it was to harden the outside of Eastern State Hospital, but now that we've been able to successfully change the scope of work of that original project, the 16.9 will assist us with addressing the original hardening work that we.
Mr. Chair, one thing I'm just wondering it's a fairly recent phenomenon that 90% of the population of Eastern State is forensic. And these changes assume that it's going to continue to be 90%. Is that accurate?
Absolutely. Well, one of the things I think to the actual physical environment itself, so they have tiles in the bathroom, for example. So it's patient safety. It's a patient safety issue as well, even if it were, let's say, a reduction in forensic. Inpatient psychiatric center, it's still not up to the standards of safety that I think we would like to see for our patients. They've been able to break some of the tiles and use that to get through. It's also a danger to the staff and themselves. So that's a big overhaul to renovate all of the rooms, to remove those things. For example.
I would also like to add that the majority of the forensic population in the NDRI are there for restoration. The folks that we're getting who are civilly committed and under TDO or forensic TDO, they have also high acute behavioral needs as well. And so they're able to utilize those same avenues to harm themselves or others.
Senator Barker?
Question for you, going back a ways to Pillar 1.
Mm-hmm.
On the slide 3, you have pursue inpatient alternatives, and the language is builds hospital-based psychiatric emergency alternatives, and or some other things.
Mm-hmm.
As that's talking about the type of proposal or effort being made, I think in Newport News, at a hospital there, to be able to provide supportive placements outside the emergency department, but at a fairly high service and cost level. So is that what that is?
Mr. Chair, Senator Barker, I think generally speaking, there is a program that we worked with. Carillion has this CPEP. And so it's a bridge program, and it provides immediate care to those that are waiting in the emergency rooms, and it's a place that's built out to support. So, for example, you go to many of the emergency rooms aren't equipped or outfitted to treat our behavioral health crisis. So this facilitates that in a way that they can receive treatment right away, providing psychiatric supports, and again, it provides the treatment they need right now. Right. So there is a program also in Chesapeake, or we're in discussions with them to develop these programs. So this request it complements the crisis service. So we'll have the CRC, CTACs, and CSUs, but then we're also going to target with our data to support where are we going to put these strategically into community hospitals or those that want to participate, again, to give them the treatment they need right then. Does that help?
Yes. Yeah. We'll
They're about
work
$3 to $6 million
dollars
for each site to develop.
All right. All right. Thank you.
Okay. Other questions? Mike, do you have anything else for us?
No, I just actually add, if you look in those amendments, talk about the psychiatric ER. Mm-hmm. That was something that the subcommittee, through the pilot project a few years ago, that's how Carillion got theirs. And something, at least what I've heard from Carillion, is works very well for them. So the other thing I'll note too, if you remember last year, the governor's proposal includes $15 million of additional monies for the school-based mental health, and that was something that a proposal from Senator McClellan that the subcommittee had endorsed and the Senate fought for, to put $2.5 million in. So this would add $15 million to that. So I just want to note that as well.
Good. Okay. Any member have anything additional? Okay. If not, I guess we'll reconvene next Monday, and we'll be busy between now and then. All right.